Good evening, and you're very, very welcome. My name is Agnes Higgins, and I am the head of the School of Nursing and Midwifery Studies here in Trinity. And I'd like to say a very, very special welcome to you all, to Trinity College, but more importantly to this lovely building, which is the home of the School of Nursing and Midwifery. I would like to say a very special welcome to our guest speaker tonight, Professor David Healy. But before we proceed, I'd like to do a few air hostess bits to remind you that there's fire exits. There's two at the back, and there's one here and one over here. If you hear the fire alarm, just make your way to the nearest exit. Can I also ask you to take out your mobile phone and to turn it off or put it on silent? Because there's nothing more embarrassing than when, and it's possibly with mine that'll go off. The format for this evening is going to be that Professor Healy is going to speak for about an hour, and then we have about 30 minutes for some questions and answers, and I'm sure we will have loads, and then we are going to have a close just from our Dean of the Health Sciences, Professor Mary McCarn, and you're very welcome, Mary. I suppose, like most of you, I've kind of been eagerly anticipating this evening for a long period of time. I suppose I was first met this man in text, and if those of you who are psychiatric nurses will remember his original text on psychiatric drugs, and I think it became the Bible for many of us. Then I had the pleasure of meeting him in person in Cork last year, and I suppose that is where I got the idea that we should invite him for a public lecture. For those of you who are not familiar with him, he is one of our own. He hails from Dublin, and tells me he was reared in Raheny, and we were reminiscing on some of the places that he would have played football as a youngster. He was educated in medicine in UCD, and we won't hold that against him, and has held chairs in Toronto, and he's now currently professor in Wales. He was the former secretary of the British Association of Psychopharmacology, and he's author of over 150 peer-reviewed articles, 50 book chapters, 20 books, and over 100 of other written pieces. He is a member of an editorial board of at least 5 journals and has presented at least 300 international conferences in his career. And in some ways you could say that resume sounds like any academic of his standing. But when he sent me what he's called his short CV, and I went back down through it, it reads very differently. Because I think if you look at some of the titles, that it tells a lot more about the person. Some of his titles is, in terms of his papers, is Academic Psychiatry for Sale, The Market of 5-HTs, Anxiety and Depression, and Science and Rhetoric. Similarly, his books tells a little tale. Let Them Eat Prozac, The Antidepressant Era. And if any of you decide to go on Amazon, and you will read quite impressive reviews about this man. But you know, some of those things don't really impress me. What really impressed me was, yesterday I got a postcard from a PhD student that has just submitted, that has gone walking somewhere in the hills. And he said, believe it or not, Agnes, in the last hostel I stayed, they had an English version of David Healy's book on psychiatric drugs. Now that really impressed me. So without further ado, can I ask you to give a very warm welcome to Professor David Healy.
Thank you very much, Agnes. It's a great pleasure to be here. When I quickly looked through the slides before this talk, I thought to myself, whoops, I've made a bad mistake, actually. I've maybe pitched the talk wrong. What we're going to do is we're going to take on some fairly complex issues. We're going to talk about controlled trials and statistical significance. I hope you're not glazing over at this point. These are things I think we all need to get to grips with, and it's going to be a case of me trying to get things over to you and hopefully keep you with me as we go, because if you want to care for people, you really have to get to grips with a bunch of issues that are at the heart of healthcare at the moment, and that's what the talk is about. It isn't going to be easy, but I will leave all of the slides behind, so those of you who are keen to get hold of all of the actual slides, you're welcome to them. And a great deal of the material that you're going to hear about is also on davidhealy.org, so you'll be able to go in there and hopefully be able to have a look at the issues there as well. What I'm going to deal with is the issue of cure and care. Obviously, in healthcare, there's this debate, there's this polarization that's been there for over 100 years, which is, are we in the business of trying to cure people, or are we in the business of trying to care for the whole person? And this debate crystallized out most clearly for the first time slightly over 100 years ago in the work of two men whom you see here. There was Richard Cabot, and Cabot was actually one of the people who led the movement towards trying to detect new illnesses, trying to create the tests that we have now these days, blood tests and x-rays and things like that, that distinguish one illness from the next illness, so that if we can clear up that illness A isn't the same illness as illness B, we can maybe find a cure for illness A. This was a big prompt towards curing as opposed to just caring. This was the kind of breakthroughs that led us on to find pills like diphtheria antitoxin, which cleared up diphtheria, which had been the biggest killer of children up till then. With doctors like Cabot, hospitals like the Mater Hospital and Vincent's Hospital and Massachusetts General Hospital over in the States began to get the reputations that they have now as the places to go to for cures. This is where the latest breakthroughs are made. Now, while all of that was happening, while the science was moving forward, there were a group of people like Alfred Worcester who were saying, wait a minute here now, this maybe isn't the only way to go forward, maybe isn't even the best way to go forward. Worcester was recognized afterwards as the father of geriatric medicine and the father of palliative care. And he said, well, it's all very well to train doctors to know all about the science, but we're in the business of trying to care for people. We're looking after the whole person. And if we've got wonderful scientists who don't know how to deal with human beings, our outcomes are going to be worse. Now that sounds all very nice, and most of you here in the room would like, in principle, the idea of a doctor like Alfred Worcester as opposed to a doctor like Richard Cabot, but in practice, you go with Richard Cabot and not Alfred Worcester. For over 100 years, we've said, well, caring is nice, and a doctor with a nice bedside approach, that's a good thing. But actually, if there's a cure, that's a good form of care too. And all things being equal, if we had a doctor who has a good approach towards us, who's extremely nice and charming, but withholds a cure, we're going to sue him. We've gone with cures for over 100 years. And care has been marginalized, increasingly marginalized. One of the things that's come on stream to help those of us who are keen on cures has been the idea of evidence-based medicine. And this is an approach that took shape over 20 years ago now. The idea was to bring controlled trials to bear on the issue of, do so-claimed cures actually work or not? The idea was to control the rogue doctors out there who may be claiming they have cures, but in actual fact the cures don't really work. We want to make sure that if we're going down the cure route. If you're going to get the best kind of care that comes from having the latest cure, that it's going to be evidence-based. And the best, the most succinct definition of evidence-based medicine is in an article that you see here, which coined the phrase evidence-based medicine. And the implication of all this is we're going to balance the evidence from controlled trials with clinical expertise and patient values. They're all going to be equal, and that looks like a wonderful world to be in. That's the best of medicine. Except the way things have gone since has looked much more like this, that the clinical trials have come to dominate everything. Largely perhaps under the influence of the pharmaceutical companies who run all the trials. It's not doctors that run the trials, it's not universities that run the trials, it's the industry that run the trials. And they've trumpeted the importance of controlled trials to the point where these dominate clinical care these days. Clinical expertise has shrunk, and the values of the patient and values of the individual doctor looking after the patient have shrunk completely down to the status of anecdotes. These things almost don't count anymore. Now, if all of that, if our turn to evidence-based medicine was really working out the way we thought it should, you shouldn't get the kind of situation that you see here on this slide here. First of all, actually, we do need to turn down the lights slightly. Jenny around? Can we dim the lights here in the front so you guys will be able to see the slides a little bit more clearly? I might be able to, no? Okay. These aren't too unclear, these slides, are they? You can see them, but it would be a little bit helpful, I think, to dim the lights at the front slightly. So, okay. This is the Edvard Munch painting. Ah, excellent. Well, we don't need... Well, we can cope with this. We can cope with this, I guess. They'll be really clear-cut now, the slides. Okay, this is the Edvard Munch painting. It's actually only the ones in the front that need to be dimmed. Whoever's in control of the lighting. Okay? Okay, this is the Edvard, this is actually the painting, the screen from Edvard Munch. Jenny, can we just dim the lights in the front? Great, okay. And this is really, this has actually been on sale this week for £50 million. So anyway, it's an appropriate kind of slide to have here. What we oughtn't to have is the kind of situation that you see here. Perfect. Right. Which is that if evidence-based medicine was working well, we shouldn't have the appearance of a new illness, which the best research we have points to this new illness as being the fourth leading cause of death now. This is out-of-date research, and there's every chance that the illness that I'm going to talk about is in fact the leading cause of death, and it is for sure within the mental health field the leading cause of death. It's an illness that you don't know the name of. It's an illness that has astronomical treatment costs. It costs more trying to treat this illness than the entire drugs budget costs. Every other illness in healthcare these days comes with guidelines. If you've got hypertension, there are guidelines for treating your hypertension. If you've got diabetes, there's guidelines for treating that. But this is an illness that has got no guidelines. Every other illness in medicine has an evidence base, but this is an illness with no evidence base, and an illness with no name. I'm going to offer you a name at the end of the talk, but if anyone else has any good ideas about a better name for this illness, I'll be keen to hear them. We know, or people generally sense, there is a crisis in healthcare these days, and the crisis is often framed in terms of conflict of interest. If only doctors in particular weren't paid by the pharmaceutical companies to give the talks that they give or to do the research that they do, everything would be okay in healthcare. Here's a bunch of profs of medicine up on the stage. It's slightly out of focus, the slide, because as you can see, these are slightly older male bodies, and we don't want to be able to focus in on them too clearly. And these are the pharmaceutical companies down below. But that's not where the problem lies. That's a myth that plays straight into the hands of the pharmaceutical companies. What I want to try to suggest to you is there's three different components to the problems that we've got in healthcare now, and you have to understand each of these, and we've got to, between us, try and work out a way to change them if we're going to get things back to the kind of healthcare that we'd like. We had a crisis about a drug causing problems back in 1962, and this led to a great change in the way we regulate healthcare and medicines. And there were three components to the system that we introduced in 1962 to try and make sure that tragedies like this didn't ever happen again. One of the components we introduced was the idea that we were going to, or we have to, reward pharmaceutical companies for the great costs it takes to bring new drugs on the market. If we give them the appropriate rewards, it'll encourage them to bring drugs on the market for the kinds of conditions that we need new treatments for. And we opted to reward them with product patents. There's completely different approaches that we could have taken. We could have introduced a system of process patents on drugs. And as it turned out, as of 62, the countries that rewarded companies by having process patents on drugs had a much wider range of new drugs than the countries that offered product patents on drugs. And the countries that had process patents on drugs had drugs that were much cheaper than the countries that had product patents on drugs. We opted instead for product patents. We didn't realize at the time in 62 that if a company held a product patent on a drug like Prozac, for instance, over in the States, they only held it in the national territory of the United States. But the system has now been extended globally, so that if a company holds a product patent on a drug, they hold it globally, and the rewards that they get from this are extraordinary. The markup on drugs like Prozac and Lipitor that you see here is of the order of 2,500%. The profit the company makes over the cost of actually producing the raw ingredient makes these drugs more than their weight in gold. These are the kinds of rewards that cause a problem for all of us, because the incentives to the companies to hype the benefit of the drug and hide the hazards are huge. We've produced the kind of situation where companies are encouraged to produce what they call blockbuster drugs. And on the previous slide, you saw a list of blockbuster drugs. Let me go back for a second. The first of them was introduced in 1985. This was a drug for ulcers. Blockbuster drugs are drugs that earn $1 billion per year or more for the pharmaceutical company. Lipitor that you see there was worth $13 billion per year for Pfizer. So with rewards like that, what companies have learned to do is to put all of their eggs in the blockbuster drug basket. They don't produce a wide range of drugs anymore. They just produce key drugs that they know they're going to be able to market to the point where they get vast returns. And the marketing, a critical part of the marketing, is to hide the risks that are linked to the drug. The next part of the system that we put in place was this. We were going to make drugs available on prescription only. Up to 1951, most drugs hadn't been available on prescription only. As of 1962, all drugs became available on prescription only. The advert, as you see here, shows her body, her choice, my decision. This is an advert for an oral contraceptive. Why am I deciding whether she gets this drug or not? Well, the thinking was, in 62, people out there on the street knew little about their health care. They could have their minds turned easily by drug company adverts. You wanted skeptical people like doctors to say to you, well, no, you shouldn't really be having these things. It's not really a good idea. It's not a good risk-benefit trade-off. That's the way things looked back then. What we hadn't recognized back then is conditions like Stockholm Syndrome. What is it? Well, a few years later, this department store, which was then a bank in Stockholm, was raided by a bunch of people with a political cause, who held the bank staff hostage for 5 days. There was a real threat to their actual lives. The Swedish army and paratroops and all kinds of things like that were camped outside the building. And in the end, ultimately, they lifted the siege, and the bank staff emerged into the light of day to find the waiting media there, eager to quiz them and sure that they were going to say that these awful people who held them hostage, who had these weird political aims, that, they really hated the whole ordeal and were scared the whole way through. And to their surprise, the media found that the bank staff said, well, these were rather nice people who were holding us hostage, and we agreed with their political aims. And that led to the recognition of Stockholm Syndrome, which happens when you're isolated, when there's a threat to your life, and in particular when your captor is kind. Now, any of you who are ever ill are isolated by your illness. There's a threat to your life, and doctors and nursing staff and others are increasingly trained these days to be kind, to say, have a nice day, and to have communication skills. This is exactly the kind of situation that sets up Stockholm Syndrome problems. So that if you're having a problem on a drug and your doctor asks you how are things going, you'll say, fine. And he isn't trained. There's not a single training course on earth that trains your doctor to recognize that behind this fine may be the fact that you're suffering badly, but you figure that you've got to keep him happy because he's the way out. So you don't want to make him unhappy by saying that this drug that he's put you on isn't working out right. The situation back in 62 was we'd have regarded doctors as very much like pilots. They were in the business of trying to keep us safe. There's been a major divergence since. Pilots, of course, there's a big difference between doctors and pilots. If you get on a plane, the pilot has a real interest in you getting to where you're going safely, because if you go down, she goes down. Doctors don't have the same vested interest. If you go down, well, that's tough. But aside from all this, the third component to the system was that we would introduce drugs that have been through controlled trials. And it's only if they've been through controlled trials and shown to work that they would be used. And this was going to be the main way to make sure that the risk-benefit trade-off worked in our favor. Let me show you a controlled trial. This is a rather famous controlled trial at this point. This is Study 329. It ended up being published. It's a trial of one of the SSRI drugs being given to children who are depressed. It's the article that you see here comes out in the journal with the highest impact factor in the field of child psychiatry. The authorship line on the article is an authorship line to die for. These are all the big names in the field. If people like this, in a journal like this, say that giving Seroxat to children who are depressed is a good idea, most doctors reading this article will say, well, really, I should be making sure that every child who's remotely depressed gets put on this drug. 3 years before the article came out, however, GlaxoSmithKline, reviewing the data from the trial, internally in the company had decided that Study 329 shows that our drug, paroxetine, Paxil, Seroxat, doesn't work. Not only that, but it's risky, and the data is so bad that we cannot show it to the FDA. They later worked out that they could show it to the FDA, and FDA wouldn't spot the problems, and they were right. But what were they going to do in the interim? They were going to pick out the good bits of the data and publish those. And that's what you've seen in the previous article. The good bits, the bits that suit the company, plucked out and published, with the bad bits airbrushed out of the picture. What you didn't see in the previous slide, the one that showed you the authorship line, was you didn't see the author of the article. You saw 22 names of people, none of whom were the authors of the article. The author of the article's Sally Layton, whom you see here, and here's an email from the company point person to her saying, I, who have seen the data, figure you've done an extraordinarily good job on hiding the problems, to the point where I'm feeling a little bit uncomfortable here. I know that the investigators, the ones who were involved in the trial, but who haven't actually seen the data, haven't raised any issues. But even I have got to go back and make sure I feel comfortable with what you've done here. Right, now, how often does this happen? Well, let's have a look. I'm going to show you now the articles, the trials that brought the antidepressant group of drugs generally to the market. And here they are. These are a group of drugs that came on the market in the States and here. And these are the trials that the FDA saw before the drugs came on the market, the trials that led to the drugs being approved. And what you see on the upper half of the slide there are the positive publications of those trials. And you see also that there were 3 trials that were done that were negative, that had been published in journals where the authors and the company say that these trials show that our drug doesn't work. Now, we've got groups who are completely independent of the pharmaceutical companies, like the Cochrane review groups, whose brief it is to look at all the published evidence and work out, well, within the cardiac field or the respiratory field or the mental health field, what are the antidepressants you should take, what are the statins you should take, what are the asthma drugs you should take, and they review all of the evidence. They really hunt painstakingly to make sure they've got all of the evidence, and based on that they come to a conclusion totally independent of what a particular company might say about their drug. They come to a conclusion about which drug they would give their husband or their wife or their children or whatever. And they suggest that if you're going to use an antidepressant, you should use the 1/3 from the right. You see the one that's got 2 boxes there, 61 and 62. This is sertraline, Lustrol, Zoloft. They say that this is the one that's got the best evidence for it. And here's their review of just that issue. This is the Cochrane group looking at all of the antidepressants and the published evidence in an article that appeared a few years ago in one of our major journals, the Lancet. Okay? But FDA got to see more trials than just the published trials that you've seen there. Okay? FDA, in fact, got to see all these trials. When you see all of the trials that were done, both the published trials and the unpublished trials, you see that actually close to half the trials of these antidepressants were negative. Not only that, but there's fewer white boxes up on top than there were in the previous slide. Why? Well, 1/3 of the previous slide's white boxes that the companies published as positive trials of their drug were, in FDA's view, negative trials of the drug. The ghostwriters have taken the trials and polished them to the point where a negative trial has become positive. Which of the antidepressants is the one that you should take now? And which is the one you should be least likely to take? Well, have a look at the 1/3 from the right. Sertraline, Zoloft. If you remember in the previous slide, there was 2 positive trials. Now there's only 1 positive trial out of 5. If there's an antidepressant you're going to take, Zoloft is the last one to take. It's the worst. Independent review of the literature is not going to save you from this. Unpublished trials are a problem. There's an even greater problem, which is published trials that are close to fraudulent. Now, I use the word fraudulent with care. Study 329 led New York State to take a fraud action against GlaxoSmithKline, which the company resolved. What I also want to say at this point is that I've been dealing with the antidepressants, but this is not a mental health issue. Any of you here in the room who are on an asthma drug, or a statin, or an ulcer drug, a PPI, or who have husbands or wives or children or parents on any of these drugs, any drug in any area of medicine, this applies to you too. We understand the picture as regards the antidepressants better than we understand the picture as regards other drugs, but you have to assume exactly the same thing applies to every other area of medicine. How bad is it? Well, this is the literature around 2004 on just these 2 antidepressants in particular being given to children, and that's what it looked like. You see repeatedly the antidepressants safe and effective, safe and effective, safe and effective. Why I've got this here is to tell you that as of 2004, the literature on antidepressants being given to children was 100% company or ghost written. There was not a single independent publication in the field. This was also an area where the divide between what the published literature says, safe and effective, safe and effective, safe and effective, was enormous between that and what the data actually showed. When we got to see the data, the conclusion was ineffective, 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 and unsafe. Now, what does ghostwriting do for you potentially? Well, among the things it does is this, and this is where things get trickier and we move into issues, the first few of which will be clear. And these are all on the blog, so you can go back and have a look at them later. This is the distribution of the suicidal acts that happened in the clinical trials that brought these 3 drugs to the market. You see that before the active trial actually begins, there was a bunch of people who had been withdrawn from the previous drug that they were on before they went on to the new active drug, or placebo. And a lot of people went on to a suicidal act during that period. Withdrawal from previous drugs can be highly dangerous. And then there were the suicidal acts that happened on the new drug being tested, Prozac, Paxil, Zoloft, whatever, and the suicidal acts that happened in people taking placebo. If you look at the published literature, however, what you see is not this, which you only get to see if you have access to the data, but no one had access to the data, what you see is this. The suicidal acts that happened previously, before the trials had actually begun, have moved down under the heading of placebo because people weren't on an active drug during this early phase, which is the same as being on placebo, isn't it? So why don't we just categorize them under the heading of placebo? After the trial was over, when the active drug and the placebo gets halted, for instance, every so often the companies will monitor people for a 30-day period afterwards. And in the case of some of the Prozac trials, one of the beauties was, let me just move for a second, this case here, where you have a person who had been on placebo during the course of the trial, and after the trial was over, gets put on Prozac by his doctor, and 10 days later goes on to commit suicide, and he's categorized as a placebo suicide. Now, let me take you into a slightly trickier area. This is, I mean, so it isn't your problem if you don't get a hold of this. It's going to be my skill in trying to explain it to you. GlaxoSmithKline were faced with a problem in 2006. And here's the problem. Look at the line major depressive disorder there at the bottom. Now that translates out, as I have it here underneath, that what they'd done was they'd done a bunch of trials, and if you add them all up, there were close to 3,000 patients who'd been on the active drug, and there were 11 people who got on to a suicidal act on the active drug. And close to 2,000 people who'd been on placebo in the same trials, and none of them had gone on to a suicidal act. These were data that were damning, a tremendous problem for the company, and were about to force them to have to warn that their drug caused people to commit suicide. How do you hide the problem? Given that at this stage, the fact that they've been moving the bodies around the place had been rumbled, and it was a little harder to do that. Well, here's a way to hide the problem that you won't believe, and you'll have to probably see a few times before you get the beauty of it. Before we actually had Suroxat, we had Prozac, which you see here. And a group under Dr. Stuart Montgomery in London had been asked to do a trial of Prozac in a group of patients who had what's called borderline personality disorder or recurrent brief depressive disorder or intermittent brief depressive disorder. And this trial, when it ran first, was stopped early and not published until years later. And when it was published, the data wasn't made fully available. But if you have access to the background material, you find that placebo was overwhelmingly superior to Prozac at a level that you just don't usually see. It was a 0.0001 level. There was just no doubt that if you're going to pick either of two agents to treat this group of patients, an SSRI or placebo, you would go with placebo. So, GlaxoSmithKline had a problem. How do they solve the problem? Well, they take their SSRI and they go to Dr. Montgomery over in London and ask him to run a trial of their SSRI against placebo. And again, they get much the same problem as you've seen in the previous Prozac trial, and they abort the trial, and it's never published because the rate at which patients go on to a suicidal act on Suroxat compared to placebo was 3 times higher. Okay, what do they do next? Well, they go to a different group and ask them to run a trial of an SSRI against placebo in exactly the same patient group. Why would they do this? And here's the trial, which again shows that that the SSRI, well, I've seen three different, I've seen three completely different data sets out of this particular trial. But anyway, none of the data sets show that the SSRI is better than placebo. Why would they do this? Well, the answer is going to surprise you. You recall this, we had this data set here, and what they're trying to do with these trials, which show that their drug is worse than placebo, is to hide the problem that you see here. How do they do it? Well, this is a group of patients who engage in lots of suicidal acts, and any decent advisor to the company would have been able to say to them, and did say to them, that what you do is you do a trial of your drug in this group of patients, because if you do it and there's a high rate of suicidal acts on the drug and on placebo, what you'll get is an outcome that looks like this. If you add 30 suicidal acts on the drug into the mix that you have before, and 30 suicidal acts on placebo into the mix that you had before, all of a sudden you can produce an outcome where the drug looks like it's benefiting people, that the relative risk of the patient going on to a suicidal act on the active drug is less than on placebo. You may need to think about that. There's about half of you here that will see this instantly, but it's what I've called a hide the boat in the harbour trick. Let me move on to an even more interesting trick, which is this. We do control trials because these days we say that the observations of nurses and doctors are worthless. They're anecdotes. Either the nurse or the doctor sees things happening to the patient and clears up when the drug is stopped and reappears when the drug begins again, but that's just an anecdote. We do control trials instead. And when you do a trial on 100 patients, you get a distribution of observations like this. You get a bell curve. If the drug's not doing anything at all, the point estimate on the bell curve lies over the figure 1.0. This means the drug's neither doing good nor bad. Okay? If the drug's doing good, the point estimate shifts to the left, so it becomes less than 1.0. If the drug's causing a problem or isn't working, it shifts to the right, so it's greater than 1.0. Okay? 1990. A fuss blows up when a group of doctors report that we have patients been put on Prozac who've become suicidal on the drug. When we remove the drug, the problem clears up. When we put them on the drug again, the problem comes back. It seems awfully clear-cut, and up till then, most views about how we prove a drug caused a problem were just like that. You observe the patient, you remove the drug, if it clears up and comes back when you reintroduce the drug, that's good evidence that the drug has caused a problem. The response from the company and the regulator and most academics was, well, no, that's anecdotes. What we've got is controlled trials, and here is an article in the BMJ where the company says you don't want to believe the anecdotes about an SSRI causing people to become suicidal. We've got the controlled trial data, and this doesn't show that people have become suicidal. If you look at the data that they publish in the BMJ, what you see is that actually there's a doubling of the relative risk. The curve that you saw before is shifted to the right. There's a doubling of the relative risk that patients on Prozac are going to go on to a suicidal act compared with patients taking placebo. Now, we can all agree with the next statement that the company makes about these data, which is that if you analyze the data, there's not a statistically significant increase in the rate of Prozac-treated patients going on to suicidal act versus placebo-treated patients. We can all agree with that, okay? Those of you who don't deal with this kind of data the whole time are now going to be in a slightly better position to appreciate what comes next. And you're also going to be in a better position to appreciate why conflict of interest, why paying doctors is not the source of our problems. 100,000 people read the BMJ. Most of them have no links to the pharmaceutical industry at all. 95,000 of them are probably hostile to the industry. Okay? Most of them don't work in mental health and have no commitment to drugs like Prozac. If there's problems there, they're going to spot them, but not a single person wrote into the BMJ to complain about what the company said next, okay? Which is that there is no increase in risk on the drug. What they said before was there was no statistically significant increase. What they're saying here is that there's no increase in risk when a 12-year-old child can say to you there's a doubling in the risk on the drug compared to placebo. This is a key point to hold on to, because this is a point at which healthcare is becoming close to psychotic. You're being told you cannot believe the evidence of your own eyes. When the issue came up first, a lot of people went along to FDA and talked about their husbands or wives or children who had become suicidal on these drugs. And FDA said, well, these are very sad stories we're hearing, but they're anecdotes. The scientific evidence says the opposite, when in fact the scientific evidence was completely consistent with the stories the patients were saying. What wives were saying about the husbands put on Prozac to stop them smoking. They weren't depressed, they'd been put on the drug to stop them smoking, they become suicidal and blown their brains out, and this was entirely consistent with what the controlled trial data showed, but they were being told it isn't consistent with. There's, in the 1960s, the tobacco industry tried to persuade people that life expectancy, they showed lots of graphs showing life expectancy increases during the course of the 20th century. Deaths from lung disease go down during the course of the 20th century, and cigarette consumption goes up during the course of the 20th century through to 1969, when all these graphs were produced under a campaign that has now become famous as the Doubt is Our Product campaign. The idea was to put doubt in your mind that cigarette smoking could be causing a problem if life expectancy was increasing, for instance. In just the same way, this is the most sophisticated version of the doubt is our product argument that you will ever see, which is companies are saying to you that if you've got drug A, which could be an awfully useful drug, but can lead to a heart attack in a small number of people who take it, a twofold increase in risk that you're going to go on to a heart attack, and this is a statistically significant twofold increase in risk. And let's say we've also got drug B, which is also extraordinarily useful, but the data for drug B looks like this, which is that there's an 8-fold increase in risk of you going on to a heart attack. What you've been told in the public domain by the pharmaceutical companies, by the regulators like the IMB and FDA, and your academics, professors of medicine and psychiatry, is that there's no increase in risk from drug B. The data is not statistically significant. If you're going to choose to take a drug, the risky drug is drug A, drug B is entirely safe. When in actual fact, if they were to treat their own husbands or wives, they would give them drug A rather than drug B, because drug B is 4 times riskier. The situation is rather like this. You've got a gun with 1 bullet in the barrel in the case of drug A. You've had a glimpse of drug B, which is a gun with 4 bullets in the barrel, but you haven't been able to confirm that. Just a glimpse. You thought there was 4 bullets there, but you don't know for sure. Which gun are you going to take your chances with? And what they're saying is, well, if I'm going to put it to my own head, I'll take drug A, but if I'm going to put it to your head, you're getting drug B. And companies hide a lot more deaths this way than by any other trick, which is in the case of all of these drugs here you see on the left, this is what's been done. You saw before that they've moved dead bodies round the place, as I've told you. This is done for for drugs like Vioxx, for instance. There were 4,000 patients in the Vioxx trials, which showed up 17 deaths on Vioxx. The placebo arm, or the other drug arm of those trials, had also 4,000 patients, and there were 4 deaths on the other drug. The company hid 3 deaths. Now, hiding 3 deaths sounds awful, but by hiding 3 deaths, they were able to publish an article which showed all of the other deaths, and they could depend on the academic community to say that 17 deaths is no greater than 4 because it's not statistically significant. Now, here's an even more interesting trick, and I hope I'm not losing you, but we're going to get back to the fun bit of the talk soon. We're going to leave all these awkward areas, but let me just introduce you to one more thing. You see the tables here, and this is the reason to leave all of the slides behind, and for those of you who want to test this out, the 2 tables there are exactly the same size and shape. Some of you will say, don't be ridiculous, and will go to the trouble, as I did, of tracing them out and superimposing one on the other and finding, to your surprise, that they're exactly the same size and shape. But even after you do that, they will still look different. And this is actually a key defense that the companies have. And how they do it, it's a trick of perspective. And in this case, the perspective is this, that the companies argue that the problems you're seeing are in the illness, not the drug. And while companies do drug trials in illnesses, this defense comes to their aid the whole time. Let me show you, and hopefully it'll become a little clearer towards the end. If you take the SSRI trials which you've seen before, which were all done in people who are moderately depressed, this is the way the suicidal acts turned out. And this is what led the companies to hide the risks, because there appeared to be an increased risk on the drug. But there was an older group of drugs, the tricyclics, the TCAs, which are more effective than the SSRIs. The SSRIs don't work for severe mood disorder. The TCAs did. The severe mood disorders are the ones that come with the risk of suicide. Okay? So if you'd done trials of the TCAs for severe mood disorder, what you get would be data that looks like this, which is it would appear that the antidepressant reduces the risk, and indeed it does reduce the risk of patients who are depressed going on to try to kill themselves. But we know from an earlier, from the 1950s, when the TCAs came on the market first, that they also, because they act on the serotonin system too, they also cause people to commit suicide. So what you've got is data from controlled trials here, where if you had a drug that was good, you could, even with a drug that caused the problem, you can use the illness to hide the problem. You with me? It's the ultimate way to hide the problem. I'm going to bring out a little bit more now in just a moment how this is done and make this a little bit clearer. But in the case of any drug that causes a problem that an illness can also cause, controlled trials aren't the way to work out is the drug causing the problem or not, because the illness will always or can always mask what the drug is doing. We're having a microphone problem, are we? Okay. Added into that, you recall this trick here, which was, it seems to have stopped, so maybe it's the thing that I was saying. Added into that was this trick here, which you've seen, which is that if you mix the kinds of people who are, if you don't understand the problem that you're putting, nature of the condition that people have that you're putting into the trial. In the case of people who are depressed, we don't know if this is one illness or a load of illness. In the case of people who've got back problems, we don't know if it's one problem or loads of problems. In the case of people who've got arthritis, we don't know if it's one illness or loads of illnesses. So in almost all clinical trials where we don't fully understand the illness, we risk reproducing what you just saw here. What you saw here before was a deliberate trick. But in actual fact, we risk in every trial we do where we don't understand the illness we're treating, reproducing just this by accident. How do we get out of the bind? Well, one of the ways out of the bind is we do drug trials. Isn't that what I've been talking about all the time? Haven't I been talking about drug trials? Well, no, I haven't. I've been talking to you about condition trials, using a drug to treat a condition, to treat an illness. It's not a trial of the drug. If you were to trial the drug, you'd give it to healthy volunteers who don't have the illness, and you'd see what happened. And you'd get an outcome that looks like this. Let me quickly show you. In 1983, 9 years before sertraline came on the market, Pfizer did a trial in 12 healthy volunteers, all women in Leeds in the UK. Half of them got sertraline, half of them got placebo. The 6 that got sertraline all dropped out before the end of week 1. They had become agitated, anxious, apprehensive. They had all the features of what this drug can do when it's leading you to commit suicide or to become violent. The results were extraordinarily clear-cut. The company didn't need statistical significance tests to tell them what was going on. The company concluded that our drug has caused this problem. Not only that, other companies have done the same thing, so the company also added in, and it is well known that SSRI drugs can do this. But this study remained unpublished, the data inaccessible. No one knows about it. So what we've been talking about is evidence-based medicine. There's a curious difference between, if you compare the word evidence in French and German compared with evidence in English. In French, evidence means it's evident. It's evident that you don't jump out of a plane without a parachute on. You don't need a controlled trial to prove this. Evidence-based medicine in English means you're going to be persuaded to do things that are not evidently good for you. It's all about proof as opposed to things being evident. You wouldn't, if any of you were anxious or depressed, you wouldn't take any of these agents here for months or years. It would be evident to you that it's not a good idea. But evidence-based medicine is all about proving to you that it is a good idea. The way we bring antidepressants on the market at the moment is through short-term trials using rating scales. And on the rating scales we use with the brief trials we have, I could, with a group of you, prove that alcohol was an antidepressant, or nicotine is an antidepressant, or Valium was, or Ritalin is. For nicotine and Valium and Ritalin, this has been proven. But what you get is the kind of situation where evidence is being produced to say to you, it is proven you should have these things, evidence that overrides your natural caution. It's because you don't understand the SSRIs that you can be persuaded into taking these drugs that we know less about than we know about alcohol and nicotine. I mean, these drugs are available on prescription only because we have every reason to believe the risks are going to be greater than the risks of alcohol and nicotine that people know and can handle. If the drugs, if the SSRIs aren't riskier than alcohol and nicotine, and you guys can handle alcohol and nicotine, why on earth do you need an expert to handle the SSRIs for you? We've moved from a world where 50 years ago, when the drugs were made available on prescription only, cars didn't have seatbelts, and they didn't have seatbelt kind of symbols. They didn't have airbags. Now, it kind of depends on the car you have. If it's a BMW, it won't start if you don't put in the seatbelt. Drugs 50 years ago came with a poison symbol on them. That's been removed as almost unconstitutional. If in a report on a hazard on a drug, I write that one of the most famous phrases in all of medicine, which is in German up here, which is that every drug is a poison, the art of medicine lies in finding the right dose, it will be removed. Or the lawyers for the pharmaceutical company will say this has to be removed. This is prejudicial against our client's compound. So that symbol has gone completely. Cars have become an awful lot safer. Drugs have become a lot riskier. What we have instead is a proposal, and we really do have a proposal. I can show you the reference if you want, to stamp antidepressant drugs with a symbol like this to overcome the scruples that pregnant women might have about having these drugs. A wonderful symbol of where we've got to maybe is this, that I kept saying about, since the system we have in place was put in place in 1962 following a problem with a drug. The drug was of course thalidomide, which was a sleeping pill which caused birth defects. And we put randomized controlled trials in place as a key way to make sure things like this couldn't happen again. Well, as of 1962, there had been only one drug that had been through placebo-controlled randomized trials before it had come to the market and was shown to work very effectively and safe. And that drug was thalidomide. We're in a world where pregnant women won't drink alcohol if they're out at a party and have a glass of wine in their hand, even though it's harmless. It'll be ripped out of their hands by half of the people there. They won't smoke, and that's reasonable. They won't take soft cheeses or uncooked meats. They probably won't take tea or coffee and won't have a hot shower. They prefer to have a cold shower, but they'll be told by their doctor that if you don't take an antidepressant, if you leave the anxiety or depression you have untreated, you're likely to cause your child birth defects. Antidepressants are now the most commonly prescribed drugs during pregnancy. 15% of pregnant women in parts of the UK are on them, even though they double the risk of birth defects, double the risk of miscarriages, which is probably the single greatest predictor of later mental ill health in women. And all the evidence at this stage points to the fact that they potentially cause cognitive impairment in the children born to mothers who have been on these drugs throughout pregnancy. What's the response of doctors to all this? Well, when the fuss blew up about the antidepressants causing people to become suicidal, the American Psychiatric Association rushed out a statement saying that the APA believes that antidepressants save lives. This is a professional suicide note. What the APA ought to have said was that we believe psychiatrists can save lives by recognizing the risks of drugs, etc. Why is it a professional suicide note? Well, if drugs are extraordinarily effective and free of risks and hazards, and doctors are hugely expensive, and healthcare costs are burgeoning, and we're trying to save money, well, who needs doctors? If nurses can be trained to prescribe as they are in lots of places in the world, and pharmacists and others, who needs doctors to prescribe? One of the worries, just to put it in a slightly different way, let's put it in Lord of the Rings type framework, which is you have the Eye of Sauron up there on the left, which is the marketing power of the pharmaceutical companies, who only market to a few people. They don't market to all of you, they just market to people like me. They have greater marketing budgets than Nike and Reebok and Apple and anyone else, but they don't have to market to the whole population. They just have to market to a few people like me, and they understand us better than we understand ourselves. They know we're not corrupted by a few £1,000 for a lecture here or there, or a trip to the Caribbean, that if we're ambushed by the media and to ask what do we go by, we'll say we go by the evidence. And that's why they put so much trouble into constructing the evidence so it looks right. But we have these hopes that others, like nurses and pharmacists, are going to pick up where doctors have failed. The hobbits will pick up the ring. It's an awful thing to say, Agnes. But the only thing is, if I call you a hobbit, I'm calling me Gollum. This is what's happened to doctors. We do not like the light. We're at risk. Well, we ultimately, as you know, out of our own interests, get the ring back to hang on to the privileges that come with the ring. We ultimately save all of the rest of you by falling into the crack of doom. Whether that's going to be what happens or not, I don't know. What's the illness that kills more people than anyone else, at least within the mental health sphere these days? Well, it's the name I've given it is pharmacosis. Whether it's the best name or not, I'm not sure. It's drug-induced death and disability. The word for me, this word actually conjures up the idea of a loss of insight. It used to be called iatrogenic death, but it's no longer being caused by doctors. Doctors may be the conduit for this form of death, but if we don't know what the risks are, if we don't know what the risks are, you can't blame us for killing you. You can blame us for, we're not directly responsible for your death. We're the agents of your death and disability, but not directly responsible. But this is the point where cure and care meet. We opened up with the contrast between cure and care. Have a nice day and cure. Well, in this case, if we're going to cure you of this illness, we cannot do it without passionately caring for you. It's going to involve doctors, our nurses, our pharmacists, standing up against what appears to be the evidence because they care and they're prepared to take risks with their professional careers on your behalf. We're on to the last 2 or 3 slides. Broadly speaking, if you've got any problems, you can tackle them from the top down or the bottom up. You can take a shower or a bidet approach to the problem. The shower options are to rewrite the system. Do we want product patents for drugs? What are we going to do about prescription-only privileges? What are we going to do about access to data from trials? The trials are run by industry these days. What I fail to say is that nobody gets access to the data from these trials. We can insist on access to the data. We can say we want database medicine, which is what most people think we've got at the moment, but we don't. Rather than evidence-based medicine, we want database medicine. The other approach is a bidet approach, which is a much greater emphasis on doctors and nurses and pharmacists and patients looking at what happens to them when they're on a drug and finding out how to believe the evidence of their own eyes again. We want to practice evidence-based medicine. There'll be a greater focus on safety rather than efficacy. No airline triumphs because they get you from Dublin to Moscow 30 minutes earlier. Airlines go out of business if they crash and don't get you to Moscow. But that's not what's happening in medicine. The companies that don't get you to Moscow aren't going out of business. The ones that claim they can get you to Moscow slightly quicker are the ones that are doing the best. That needs to be turned around. We need greater... We don't have the access to data from trials these days, the trials that are done in people who are ill. We have a register of trials, so we know the trials that are happening. But in the case of drug trials, that's the ones that happen in healthy volunteers, we have no access to the data and no register that they're even happening. This needs to change. I've got a big conflict of interest in this talk, which is, along with colleagues, we're just in the business of trying to create an adverse event reporting website, which will be risk.org, where people can go and report adverse events that are happening on the drug. We're hoping to get patients and nurses and pharmacists and doctors working as teams to do just what I've outlined to you, on the basis that when we go back and look at whether people get it right when they report on adverse events, it turns out that in at least 80% of cases, people who report an adverse event on drugs are correct. And it's not just doctors who are correct. It's hairdressers can get it right. Oral contraceptives change the texture of your hair. It was not a bunch of doctors that made this observation first. It was either the women on the oral contraceptives or their hairdressers, or both combined, that got the observation right. So it doesn't have to be doctors. Back to the pilot and the doctor. When doctors report on adverse events, it's dismissed by the IMB as anecdotal. If a pilot reports on a near miss, it is not dismissed as an anecdote. This is the kind of material we use to make flying safe. And it's the kind of material that if we ignore, medical care cannot be safe. Just a quick instance on this. This is worth going to. This is the final thing to end up with, really. This is on the blog, and it's two bits to it. It's American Woman 1 and 2, and it outlines a case where a woman reports to GlaxoSmithKline that she's been taking their antidepressant, Seroxat. You aren't going to be able to read it here, but the story quickly is this. She desperately tries to get through to the company and says, look, my husband and I wanted to have children, and I was actually on Seroxat because I had panic attacks, and it helped me wonderfully. I'm not saying anything bad about your drug. It's been great for my episodes of anxiety. But I need to know, can it cause problems to children in the womb? Because I got pregnant and went along for an ultrasound scan and was told that my child had truncus arteriosus. This is where the arteries and the heart just don't match at all. Good chance the child won't be born alive. If it is born alive, it'll have to have a series of major operations if it has any chance of being able to live, and even after the operations, there's a good chance that it won't live. So she had a termination, but she still wants to have a family, so she wants the company to let her know, is there any evidence that Seroxat can cause birth defects? And the company write back and say, well, here's the product information on our drug, which says nothing, and go and talk to your doctor, who, of course, has been told that the drug can't cause these problems. And she writes in again one more time. It's worthwhile to go into the blog and read the emails. And she said, look, I really need to know, is there any research happening on this issue? Internally, the company have looked at her case and have decided it's almost certain their drug caused her problem. They don't tell her this. But the key point behind putting all this here is this. When you look at how hard it was, and that's in the next bit of the blog, for her to contact the company, you will find that it's almost impossible for any of you, if things go wrong on a drug you're on, to actually get the message through to anyone who is going to take this into account and change the system as a consequence. That's what needs to change. We need to restore evidence-based medicine so that your observations and values and those of who are, the observations and the values of people involved in your care, whether nurses, pharmacists, or doctors, count for more than anything else. Everything else is good. It's good to have controlled trials. These are good things. It's great to have that data, but it shouldn't be trumping everything else. Thank you.
Thank you very much for, I suppose, what it was a disturbing presentation in lots of ways. And I suppose I don't mind being called a hobbit because
I'm Gollum.
Hobbits can do lots of things. So we have a few minutes for questions and answers, and David is happy to take some questions.
Well, I think the one thing I can do is giving a talk to perhaps doctors like you, is to say that if you don't take this into account, you aren't going to have a job soon. You are going to be replaced. I mean, increasingly, healthcare systems are being run by staff who have no background in healthcare. They're the same kind of people who run big tobacco or big oil or big auto. They're brought in to manage the healthcare system. And one of the things they're going to look at is the fact, well, it's drugs that cure people, not doctors or whatever. And if you're awfully expensive and we can get the drug prescribed by a nurse or whoever else, well, that's what we'll do. So it's in your interests to say drugs don't necessarily work all that well. They come with huge risks, and you need a well-paid person like me who's been trained the way I have and who's because of these risks, that you can't, it's trying to treat people isn't the same as trying to build a car on a Ford motor plant, where sort of all the bits are absolutely the same, and we can, the way the way to assemble the car is to break the job down into its component parts so that anyone can do the job. That isn't the case. You are going to have to insist that professional discretion is important. Yeah, okay, well, what I think we need to do is, it's not quite a first do no harm approach towards things, but it is the aphorism from Philippe Pinel, which was, there's an art in medicine which is knowing when to give a treatment that may help, but there's an even greater art in knowing when not to treat. There's a whole bunch of things here. We're in a world where the focus is on beating cancer, and this is this point I'm going to make mainly for Agnes. The focus is on beating cancer, for instance, which means taking huge cocktails of drug to try and kill off the cancer. But beating cancer for me or you may mean actually making sure this illness doesn't beat us in the sense that we become too focused on the illness and the treatments, and that's all we end up. It may be a case of, well, saying, look, I have this illness, it is going to kill me. In the meantime, I have projects that I need to get on with. I have things to do in my life. So beating cancer may mean not letting it beat us in that sense, okay? Now, we've got a world at the moment where doctors have become heavily focused on just curing as opposed to knowing when not to treat. pharmacists and nurses can help in the process hugely here by supporting the patient in things the doctor used to be good at but isn't these days. It's, on being able to give them information about drugs that the doctor doesn't give them. And often it'll be easier for the patient to go to the pharmacist because they recognize that, you're going to make this man unhappy if I say the treatment that he's put me on has caused a problem. But the pharmacist is often viewed as a much more independent source of information about what the pros and cons of the drugs may be. They know how to search the databases on these things much more than doctors do. So it may not be simply a case of nurses prescribing or the pharmacist also prescribing, because just like you, I think once they prescribe, the industry will focus in on them. The eye of Sauron will turn on pharmacists also, and I don't have any reason to think that you guys are going to be any better than us when it comes to this. The pressure is huge and extraordinarily subtle. What I'm hoping, though, is we need to recreate a world where patients and nurses and pharmacists and doctors work as teams. If you have one patient or one doctor that reports a problem on a drug that clears up when the drug is removed and reappears when the drug's reintroduced, the world probably doesn't believe them. But if you've got a few patients a few doctors that actually report the problem, the world's more inclined to believe them. If you've got combinations of doctors and patients and nurses and pharmacists all endorsing that this did happen, then again the world is much more likely to believe that it did happen. And they're the kinds of things that I think we need to do that we aren't doing at the moment, and that hopefully the website will help. Yes, I've got a bunch of thoughts, and this may not be a quick answer. Are these working? It's probably slightly easier to stand over here. Can you hear me still? Yeah, okay. Yes, I think there is a way in which the crises do correspond. And one is that what the industry has been able to do, which is a bit like what the financial system did, which is to cut up risk so that it appeared to disappear. And all of a sudden, I think there's probably a feeling within healthcare which is a little bit like the feeling there was, I think, a bunch of people, I think, had 4 to 5 years ago before the banking crisis struck, which is, this is great, wonderful, marvelous, we're doing wonderfully, our houses are going up in kind of value the whole time, but it can't go on. Lots of other voices said, well, yes, it can, but I think there was a bunch of people who said, look, this can't really go on, it is going to crash. I think there's a feeling in healthcare that's a bit the same, that this can't go on, it is going to crash, and the issues are a little bit the same, which is that you're being told there is no risk. The risk has been chopped up using the tricks that I've outlined here, not just in the mental health domain, this applies across healthcare. The risks have been chopped up so they appear to vanish, but they aren't gone. Having said that, I'm not sure I agree totally with your view about greed and things like this. Let me put it like this. One thing you don't want to think in terms of trying to solve the problem here is you don't want scientists or doctors or people like that to be saints, to be particularly moral. The whole point behind access to the data, the conflict of interest argument is all about doctors shouldn't take money from the drug companies. We want them to be saints. That's not actually what science is all about. It's about access to the data. And in a sense, we want people to have conflicting motives people to be trying to prove particular points of view because they're being paid money, people trying to take the opposite point of view for all kinds of other reasons. Okay? A lot of scientists down through history have been close to deluded. And it can require that kind of motivation to come up with the kinds of answers that we need. So when you have access to the data from trials, that's the thing that moves the field forward. It's not the individual virtue of a particular scientist or a particular doctor. It's access to data. One point, though, which I would just prompted by the question you've asked, which isn't quite an answer to the one you've asked, but it's a point I like to make, and it's potentially applicable here in Ireland in a way it wouldn't be elsewhere. We've had the child abuse problem with the Catholic Church. And part of the issue there was that under the influence of Freud within the mental health sphere, we learned that not everything that people say can be believed. That there's the things that we say, and you have to look often for the hidden meanings underneath what's being said. And this was a great breakthrough, but it ultimately led to the point where people said, well, you cannot believe anything that people say. And when complaints of child abuse were brought forward, they were dismissed because this isn't what actually happened. We know the true motivations behind what these people are actually saying. And the church found out to its cost that, well, actually, when people complain about being abused, there comes a point where you have to take what they say at face value. We're in a little bit the same kind of position with controlled trials. They operate a little bit in the same way as Freud did. They've taught us a huge amount about the biases that both doctors and patients bring to clinical care. The wish that the treatment will work and things like that. That's what controlled trials do for us, and that's hugely useful. But if we get to the point of saying that every observation of a doctor and a patient is biased and can't be believed, we've gone too far. And in exactly the same way that the church and others went too far and said that these things can't be believed, within healthcare today we have gone too far. We need to get back to recognizing that things that go wrong on treatment may actually be going wrong on treatment. That's a hugely complex question, and it would take ages to go into it. The book, for those of you who haven't heard Bob talk and haven't had the opportunity to read the book's well worthwhile reading. He and I both think there's problems. We don't agree fully on the nature of the problems or the answers to them, but he's on board with the idea of helping me create risk.org, so he's also actually involved in that. That's about all I can say for the moment. It would take a long time to go beyond that. The antipsychotic, well, what's awfully unfortunate here is I wish in ways I could be here giving you a talk actually about schizophrenia and data. We've got huge amounts of data on this illness, its rise, and it appears to be disappearing. And I would love, as opposed to talking about these issues, to talk to you all about what might be leading to its disappearance. We don't have any cures for it. The treatments we give are rather like aspirin for arthritis. They may be helpful, they're certainly not curative. And the art really is trying to find how much help you can get from the antipsychotic group of drugs. And it's a bit like aspirin. If you treat an arthritis with one of the aspirin group of drugs, and you get some improvement with these pills, it isn't the case that taking more of the pill will necessarily help you more. It may just cause more complications. You may have to accept that there's only a limited amount of help that you can get from the pills, and the trick is knowing when to use the pills, when to up the dose a bit, when to put the dose back down a bit, and even more to the point, knowing, well, if the pills aren't the answer, what else can I be doing? And trying to get a package of care that will involve pills and other things also. It's exactly the same for the antipsychotic group of drugs. They're not curative. They can be extraordinarily helpful for what are called acute and transient psychoses, but for more enduring problems, they're not curative. And the trick is learning how to use them as opposed to becoming reliant on them.
Now, whether you agreed or disagreed, and like me, I'm sure there are things that I wholeheartedly agree with, and then there's things that I would maybe have a different perspective. And it has challenged me to think about, I suppose, our whole focus on Cochrane reviews and what that means. But I would like to say a special thanks to David, but I would like to introduce you to Professor Mary McCarn, who is the Dean of the Faculty of Health Sciences here in Trinity, who is going to respond with a few words. Thanks, Mary.
Very much. Okay, firstly, I want to thank Professor Healy, for what I would say was an absolutely stimulating and provocative and interesting and challenging presentation. I want to congratulate the School of Nursing and Midwifery and Professor Higgins and her team for inviting Professor Healy, and it is debates and discourse like this, I think, that is so critical, because it is challenging us and broadening our minds with respect to, I suppose, what sometimes becomes as accepted practice. I know at the start of Professor Healy's presentation, the statement he first presented to us was, if you really want to cure people, well then you have to care about people, and we have to come to grips with many complex issues. And I think Professor Healy demonstrated tremendous skill tonight in presenting what was indeed very complex issues, a very different way of presenting statistics, perhaps, in a much more interesting way than many of us perhaps have learned in the past, but certainly a way that challenges and questions us. I suppose it is concerning, and I know Agnes did mention being somewhat troubled by the presentation, and it certainly is troubling when we think that perhaps we can look at data and in people who we are trusting with data, and that we can fix data and play tricks with data. I mean, that is concerning for people who we probably have entrusted with this work. And I know this gentleman here, and it was interesting that you should have, in some way, I suppose, compared this or drew an analogy to what happened in the current crisis here in Ireland. But I suppose when the price is so high, the risks also become high, and people do risk when their price and the rewards are so high. I think Professor Healy's talk was not about no role for medication. I think he made that very clear. And I think that he made it also very clear that he was not saying that illnesses aren't real. Illnesses are real. And there is a role, certainly what I picked up, and I hope I'm correct in my interpretation, Professor Healy, was that there is perhaps a role for medication, but we need to understand that role. And when we think about perhaps what constitutes evidence, and what is evidence-based medicine, I suppose one of the things that I picked out from what Professor Healy was saying, perhaps we have been very driven by industry-based medicine and industry-based evidence versus evidence-based medicine. And I think there is somewhat of a difference there. And I suppose it really, for me, certainly has challenged us to rethink about what is evidence-based medicine and the need for evidence-based healthcare, and understanding, I suppose, the role of other healthcare professionals and the fundamental voice and the role of the patient in contributing and building up to evidence. And I suppose, you know, questioning what we call anecdotal evidence or evidence that isn't real. And I think Professor Healy has managed, perhaps, hopefully, to stimulate the broadening debate on what constitutes evidence-based healthcare and evidence-based medicine and what crystallises that. I think it is hugely important, the whole discussion in relation to access to data. And I think that is a debate that I would like to see continuing, and it is very concerning. I'm not sure how many people realise that, you know, who is the group that is actually analysing and producing this evidence with respect to the product at the end of the day, who are also the sellers of this product, and I think that is important. I just want to thank Professor Healy again and the school. I think it was a very stimulating and interesting presentation, and hopefully will be something that we can build on and stimulate further discourse and discussion. So thank you very much. Thank you.
So just to conclude, I suppose I want to say a special thanks to Professor McCarran for taking time out this evening to come out of her busy schedule. And I say a special thanks to Louise and Brian and Jenny, who, as always, stepped in and helped to organise the event. And to Trinity College, who generously gave some money to say that we could have Professor Healy here through the professorship fund. And I suppose to you, more importantly, for coming out, participating, and for asking very pertinent questions. So I think tonight is just the beginning of, you know, a conversation that needs to happen, and needs to happen not just in mental health care, but I think in healthcare in general. Now, I know some of you have given, you know, when you were enrolled in that, and Jenny has kept people's names and emails. And if you want to continue to stay on the database, we will be, in terms of if you want to be invited to other public lectures and that we hold here, we would be delighted to hear from you. And just to say good night and safe home. Thank you.